Hi, good afternoon, everyone. I'd like to thank Sages and the panel members for inviting me to give this talk. These are my disclosures. Okay, so I'm going to talk a little bit about Botox and its applications in abdominal wall reconstruction. So Botox, most people, when they think of Botox, they think of cosmesis and its applications in Hollywood. But Botox is a medication over the last 10 to 15 years that have had many other clinical applications. So more commonly, Botox can actually be used to treat migraines, depression. We use it sometimes in esophageal motility disorders, and now even in abdominal wall reconstruction. So what are some of the perceived benefits of Botox in complex abdominal wall reconstruction? And so as Dr. Augustine had presented, sometimes we face challenging and complex patients, and we're really faced with the inability to close the fascia. And as we all know from many hernia studies, when we're not able to close the fascia, we have much higher rates of hernia recurrence and much less rates of ability to create that optimal outcome. And so in many of these patients, when you have loss of domain and ability to close the defects and decreased compliance in the abdominal wall, you're really trying to use every tool in your armamentarium in order to get the abdominal wall closed. So in order to do that, I think Botox is a really great adjunct tool that we can use to bring things back together. In some of these patients who've had prior component separation or decreased compliance, this will be incredibly important. So what is the mechanism of Botox in the abdominal wall? So Botox is really a neurotoxin derived from Clostridium botulinum. And what it does is it blocks acetylcholine release at the neuromuscular junction. And this causes a flaccid paralysis that is noticeable in about 2 to 4 days with a peak effect in 2 to 4 weeks. And the duration on the abdominal wall can really last upwards of 3 to 6 months. So this was first initially described in 2006 in a rat animal model in which they used it to relax the abdominal wall and increase intra-abdominal hypertension or pressures. And it was first described by Ibarra Hurtado in 2009 in 12 complex patients. And so this is a really great article by one of my colleagues, Ava Derenberg, where she talks about the Botox injection technique. So I'm just going to go through this fairly quickly here. So a lot of times when you inject Botox, you're talking about injection in the 3 abdominal wall muscles, so the external oblique, the internal oblique, and the transversus abdominis. There's really no consensus out there in terms of, do you inject all 3 muscles? Do you inject 2? There's been studies that kind of show maybe there's no clinical difference if you inject 2 versus 3. And so I think that's one of the things that we're still trying to figure out with this new technique. So depending on how many muscles you're injecting, you can inject anywhere between 200 to 300 units of Botox, or a little bit more for Dysport, which has a lower concentration. You actually dilute the Botox in a 2-to-1 formation. So if you're doing 200 units of Botox, you would actually dilute it with 100 cc's of normal saline. And so you would do 3 injection sites on each side bilaterally, and you would inject each muscle that you're planning to chemically relax. So in this particular case, if you're doing 200 units of Botox, you're actually going to be injecting 16 units of Botox per muscle with a total of 6 to 9 injections per site. And so now that we've talked a little bit about the techniques, I really want to talk about the current evidence for utilization of Botox in complex abdominal wall reconstruction. So currently it is off-label use, and it's not approved by the FDA for abdominal wall reconstruction. And so I think our patient selection and our patient outcomes are going to be incredibly important as we talk about which patients are potentially best optimized for this technique. So in this 2009 study by Ibarra Hurtado, he essentially in these complex abdominal wall patients who've had previous open abdomens, he injected Botox and CT scanned them, before and after Botox injection. What he really found was that there's a mean reduction in defect size by about close to 5 centimeters. So taking that medium width defect size from 13.9 centimeters to 8.6 centimeters. And these 12 patients, he was able to achieve 100% fascial closure and a 0% recurrence rate at 49 months. In a follow-up study in 2014 with a series of 17 patients, he demonstrated something very similar. And in this study, he actually measured the length of the abdominal wall muscles and the muscle thickness after the effects of Botox. So in A, you see the pre-Botox injection, the abdominal wall muscle length is about 8 centimeters, and then post-Botox injection, 4 weeks later, that's about 10 centimeters. So most of these patients, they gained a mean of almost 2.5 centimeters increase in abdominal wall length. He also noted that the muscles decreased in size by about an average of a centimeter in that 4-week time period. And so at 4 weeks, the mean reduction in defect size is really close to 5 centimeters, along with an increase in muscle length and a decrease in thickness. In this follow-up 8-patient study, this demonstrates something very similar in terms of abdominal wall elongation with Botox toxin. And in this particular study, post-Botox, you see an average increase in lateral abdominal wall length by about 2.8 centimeters per side and 100% fascial closure. This has also been demonstrated in patients who undergo complex laparoscopic hernia repairs. So in this study of 32 patients, there's also demonstration of elongation and less ballooning of the hernia defect by preoperative Botox injection. They found that there was a mean increase in lateral abdominal wall length by about 4.5 centimeters on each side, so about 9 centimeters total, with a reduction of the hernia defect size up to 58%. And all of these patients ultimately underwent an IPOM repair with primary fascial closure. And perhaps the largest series examining Botox on abdominal wall reconstruction comes from Todd Hunterford's group out of Carolinas Medical Center. So in these complex patients with a mean width of about 15 centimeters in size and an average hernia volume of greater than 2,000 cubic centimeters squared, what we found is that fascial closure rates with administration of Botox is 91%, which is pretty high. And if you look at the component separation required for these complex patients, it's really only about 57%, indicating that Botox can potentially decrease your need for component separation and improve your capability to close these complex defects. So in these 108 patients, most of them had midline or flank hernias. They were also classified by the European Hernia Society classification based on location. Mean average of Botox units received in these patients was 243 units, about 32 days prior to surgery. There were no reported Botox-related complications. Most of these hernias were very complex. 57% of these patients have recurrent hernias. I think 30% of these patients actually had contamination with high CDC wound classifications prior to surgery. What they also found, which I thought was kind of interesting, is that 88% of the subxiphoid or M1 hernias actually required a component separation versus 50% of those that did not have an M1 hernia. And overall complication rates were higher in those that needed a component separation technique. And recurrence rates were about 6% after 14 months of follow-up in these complex patients. And so this is perhaps one of the only studies that's out there that is really a match study comparing Botox versus patients who did not receive Botox. This is a propensity scored match study also done by Todd Hunterford's group out of Carolinas Medical Center. And so these patients were propensity scored based on BMI, width, and hernia volume to intra-abdominal volume. And what they found was that there's a significant increase in fascial closure with Botox, so it's 92% compared to 81%. They also found, interestingly enough, that there's a higher rate of component separation in the group that underwent Botox, which is kind of contrary to what you would think. And I think the reason for that was because the patients who underwent Botox actually had higher rates of M1 hernias or subxiphoid hernias, and therefore required more component separation in order to close the fascial defect. The study also demonstrated that Botox did not increase complications or recurrence rates in these complex patients, which I think is surprising, but also demonstrates that its utility in these complex abdominal wall patients. And so overall, there was really no significance. In fact, actually the group without Botox had a higher rate of surgical site infection than those with Botox. And if you look at the recurrence rates at 14 months is 9% in the Botox group and 12% at 29 months in the non-Botox group. And average length of stay, I believe, was very comparable between these two groups. And so we've talked a little bit about, the evidence showing that Botox can really increase your rates of fascial closure and your ability to do good hernia repair for many patients. But what are some of the drawbacks and some of the complications? And in reviewing the literature, most of these patients actually have very minor side effects. So less than 5% of patients actually have a Botox-specific complication. Most of them report some pain at the injection site, possibly some superficial bruising, a weak cough or sneezing, abdominal bloating, or perhaps back pain. Most of these resolved fairly quickly, and almost all of them resolved after hernia repair. And so while there's many upsides to utilizing Botox for complex abdominal wall reconstruction, there's still some limitations. So it is not approved by the FDA currently, and really there are no randomized controlled trials examining Botox versus non-Botox in these complex patients. I also think one of the challenges that faces Botox is we're really limited in our ability to measure the compliance of the abdominal wall. Most of the studies that we've really looked at so far really measure the abdominal wall in terms of muscle length and looking at CT scans, but there's really no surrogate marker for abdominal wall compliance, and I think that's one of the things that we're really missing. As we all know, looking at a CT scan of a patient with an 8-centimeter defect doesn't necessarily predict whether or not you can close them. I think some of that is based on physical exam. And so I think without that real ability to measure compliance, I think it's really hard to measure the true effects of Botox on some of these patients. And of course, we're using them on a very heterogeneous patient population, all of which, have complex hernias. And sometimes it's really hard to gather data and really make really sound conclusions based on that population. And of course, there's no optimal concentration or dose or guidelines about how exactly we should use Botox in these patients. And so I think some of the future directions that come from these studies should be inclusion of randomized control trials to really demonstrate the effects, demonstrating how we can measure maybe the effects of Botox more accurately outside of just CT scans. I think we really need to talk about defining the optimal patient population and create guidelines and consensus on dose, concentration, timing, and optimal usage of Botox in these patients. And I think ultimately, my biggest question is going to be, is this going to be able to replace, a traditional component separation? And I think that's something that will be really interesting to see, and I'm excited to see if that's going to be something that ends up happening in the next 10 to 15 years. And so some of the key takeaways are going to be, I think Botox is a really useful adjunct for complex abdominal wall repair. And it's an important tool in the armamentarium of a hernia surgeon. I think patient selection right now is key in deciding which patients would benefit the most from Botox. And if you're going to do this in your practice, is to establish a protocol and work with your interventional radiologist and your patients to determine exactly how you're going to dose and time in relation to your operation. Thank you so much for your time. I look forward to your questions.